for inviting me today. It's a pleasure to be here, and I have to say to all my patients, you've already heard all of this, so next year I think I'm just going to leave the slide deck and one of you can give the talk. Here's the usual disclosures. Mucopolysaccharidosis is a rare disease. About 1 in 25,000 people are born with it, but mucolipidosis is much more rare than that. And when I gave the talk to a family meeting a couple of years ago, people were very upset that I hadn't included mucolipidosis, so I thought I'd try and do that today. But because of its rarity, there's not a lot written in the literature. So you can find that it can be as rare as 1 in 600,000 births. If you look at the papers that have been written about mucopolysaccharidosis and mucolipidosis over the years, you can see how the number has increased in the blue line. Up to about 200 to 250 scientific papers a year are written just with the topic of mucopolysaccharidosis. Unfortunately, for mucolipidosis, the number has rarely passed 50 papers a year due to the rarity of its occurrence, I believe. What you can find when you look in the literature is that they're different, but they're really very similar. There are many types of mucopolysaccharidosis: Hurler, Hunter, Sanfilippo, Morchio, Merito-Lemay, Sly, and MPS IX. There are really only 2 types of mucolipidosis that we talk about, types 2 and 3. They're similar in that there's progressive accumulation of storage material in all the cells of the body, and that affects all parts of the body, including the heart. Mucopolysaccharides are naturally occurring compounds. We all have MPS in our body. It's what gives us 3-dimensionality. And some of us, me included, have a little more 3-dimensionality than others. One of the things that you don't think about is what does a GAG, a glycosaminoglycan, do? And for the heart valve, for example, it gives thickness to the heart valve that functions as a shock absorber. If you think about your mitral valve opening and closing 80 times a minute, 100,000 times a day, if you took a mitral valve, it'll do that for 70 or 80 years. Now think about if there weren't gags there and it was like a piece of paper. About the 10th time you folded it, it would just come apart. And so gags function as shock absorbers and keep your tissues from fraying at the edges. And so gags are a good thing. It's only when you can't keep them in balance that it becomes a problem. And so that's the case in both mucopolysaccharidosis and mucolipidosis. And there are different ways for diagnosing them. And for the MPSs, we all know that it's by the absence of a specific lysosomal enzyme. But for the mucolipidosis, it's a totally different way of diagnosing the patients and can be quite involved. So what do you need to know about your heart if you have MPS or MLS? Well, storage material can increase the thickness and the stiffness of your heart. If you have storage material in the walls of the heart, that can cause increased stiffness to the heart, so it makes it harder for blood to get into your heart. They call that diastolic dysfunction. If you have increased storage material in your valves, you can have problems with leaking or stenosis of your valves. And so this is a 2-dimensional echo of a normal 20-year-old. And this is the left ventricle, left atrium, and mitral valve. I'm going to run it, and you can see how the mitral valve and over here the tricuspid valve, they open and close, open and close. And this, on the other hand, is a 20-year-old with mucopolysaccharidosis. And I think you can see how thick that mitral valve is in comparison to this mitral valve that has no mucopolysaccharidosis. So valves that are thick, they can either leak or they can become stenotic. And if you look at all the literature for MPS, pretty much any type of MPS, the thing that is most common is leaking of the mitral valve. And it's a progressive phenomenon. And so it may increase over time in untreated patients. So you can actually see mitral regurgitation on two-dimensional echo with color. And what you see is this funny greenish, yellowish, bluish signal here. That is the mitral valve leaking. The blood should be going into the heart and out of the heart, into the heart and out of the heart. And instead, there's leaking of the mitral valve, and some of it goes backwards into the left atrium. Same thing, you can see aortic regurgitation on cardiac ultrasound. Remember, here was the aorta, and you can see blood going out, but you see this turbulent signal coming back down into the pumping chamber. That's aortic regurgitation. That's something that we follow in patients who have MPS. And happy to say that for the bone marrow transplant patients, what I've found over the years is that the changes are very slow and they're very mild, especially on the most recent bone marrow transplants for the last 10 or 15 years. Less common with MPS is mitral valve stenosis. And here's that same picture with the mitral valve here in the left ventricle. And now I'm going to show you the turbulence. This yellow and green sparkly stuff is turbulence of flow across the mitral valve. Come on, baby. There you go. So you can see this yellow signal. That tells you that the flow is turbulent and there's a pressure gradient across the mitral valve. So if there's a pressure gradient across the mitral valve, that means that there has to be a higher than normal pressure in this collecting chamber to shove blood across the valve and get it into the pumping chamber. So we can actually get numbers annually when we do echoes on patients for this obstruction, and we can follow those along every year. And so that would be what you see on the echo report, the mean mitral valve gradient. And same thing with the aortic valve. You saw the aortic insufficiency, but you see just this little bit of turbulence, a little bit of yellow and green going above the valve here. That's aortic stenosis. And mitral stenosis and aortic valve stenosis are much less common in patients with the MPS disorders. And the regurgitation is much more common. You can also get storage material in your coronary arteries, and that's the blood vessels that supply your heart muscle itself. And this is a nice coronary artery taken from a 3-month-old child who didn't have NPS, and you can see the lumen of the vessel is quite large. And a lot of the patients who come to us as babies with MPS for bone marrow transplant can already have substantial deposition of the storage material in the coronary artery. And this little bit right here is the lumen. So I wondered if there was the same process in mucolipidosis, and there's really not a lot written. They're pretty much limited to case reports, but there was coronary artery narrowing similar to this, found in a 3-year-old with mucolipidosis at the time of postmortem. So I think it can occur in mucolipidosis as well. So, to summarize, they both have increased wall thickness from deposition of the gags. They both have increased valve thickness. It's the mitral that leaks mostly in MPS and the aortic that leaks in MLS, and they both can have coronary artery involvement. So, if you talk about standard therapy, there's a valve replacement, and they've both been reported, valve replacement has been reported for both MPS and MLS. Now, it's been reported many, many, many times in MPS, and usually in adults, and oftentimes in adults with a milder form of the disease who haven't been treated with even enzyme replacement. There's only one report of a valve replacement that I could find with MLS, and that was an aortic valve replacement in a 9-year-old with ML3. So the valve, this is a St. Jude valve made in the Twin Cities, and it's a bi-leaflet valve, so it's kind of cool. It opens from a center strut here, and you can even see it on x-ray. We have the pediatric residents learn that if the valve gets stuck or clotted, it won't open all the way, so we look for a touchdown sign, closed and open, touchdown. And so that's a good valve. And if you see one leaflet doesn't come up, then you know that there's an issue. Anyway, this is a prosthetic mechanical valve that has been placed in a large number of patients with MPS and at least one with MLS. So new and written about in MPS 1 and performed here as well at the university is what they call a transcatheter valve, and that is a valve that you don't need heart surgery for. You can have it placed in the heart cath lab, and we've done it in an adult who has MPS, and it's also been reported from London in another adult with MPS. In this case, the valve, here's the valve leaflets, and the valve is on a cage with chicken wire stent, and so the valve is wrapped around a catheter, and the catheter is put in your femoral artery and delivered up into your heart, into your aortic root, and when it's positioned in exactly where they want it to be, right where the aortic valve, the old aortic valve is, they deploy the stent, and a stent opens up and mashes the old aortic valve against the wall, and voila, you have a new aortic valve. So that's something that is done in adults all the time, in high-risk patients, older patients, and it's done with good results, good short-term results. Two issues. One is that, you know, there's not 10 or 15-year follow-up for these valves, and so it's possible that they would need to be replaced by another transcatheter valve if they develop leaking or stenosis on their own. The other thing is size. They're designed now for adult sizes, so it's important to make sure that there is a catheter system and a valve that's the right size for people who may not be full adult size. But that's coming along in research, and also people are doing the same thing with a mitral valve. So in 5 or 10 years, I imagine that there will be that it will be standard to do catheter replacement valves. It's kind of cool. Bone marrow transplant has been reported for MPS 1, and it's actually the standard of care for hurlers. There's more than 500 of them that have been performed over the years, and we now know that patients live well into their adulthood. We have some patients that we've transplanted at the university back in 1983, 84 that we still see, and they're doing great. They're grown up, working, and it's leading a fairly decent life, I would say. For MPS 2, the Japanese have got a big series of bone marrow transplant for MPS 2, and it hasn't been the standard of care in the United States, mainly because of the presence of enzyme replacement therapy. But I think that bone marrow transplant is is still up for discussion for MPS II, and Dr. Munzer probably knows better than many of us about what the pros and cons are for bone marrow transplant for MPS II. Back in the beginning, when we were doing transplants back in the 80s, we did transplant some patients with MPS III. Others have done it as well, and unfortunately, it really doesn't help the neurocognitive decline that occurs in MPS III. There are case reports of MPS IV getting bone marrow transplants with good results. There are cases of MPS VI that have been transplanted with good results. Our first patient here at the university was transplanted with MPS VI and lived well into her 40s. There are case reports of MPS VII as well. So this, for MPS I, there's a good rate of engraftment and there is good long-term outcomes. There's only one paper that I could find that talked about bone marrow transplant in ML2, and worldwide there are only 22 patients that were found. There is again a 30-year follow-up. There was not a great outcome in terms of survival. I think the paper said that only 6 of the patients were still alive when they did the follow-up. So after bone marrow transplant, there are issues. There's bony issues, valve issues, there's lung disease issues, there's growth issues, corneal issues, ENT issues, and sometimes neurodevelopmental issues. Same thing for mucolipidosis after bone marrow transplant. So for my organ, cardiac function remains generally unchanged from what it was before bone marrow transplant. If you go into bone marrow transplant with a normal ejection fraction, I'd expect to see the ejection fraction, the squeeze, be normal 10 or 20 or 30 years later. It looks like the coronary artery disease that occurs in MPS either gets stopped or reversed because we have nobody dying suddenly for unknown reasons late after bone marrow transplant. The thing that bone marrow transplant doesn't seem to fix is the valves continue to be thick and they may leak some more. The mitral and the aortic may leak some more. We've had very few patients who have needed valve surgery. Most patients have no symptoms from their leaky valves, and a few of them are on cardiac medications. So the paper that talked about the bone marrow transplants that I just showed you on the previous slide said that there was progressive cardiac complications in the patients with MLS who had bone marrow transplant. There wasn't a lot of data in there, so I can't tell you exactly what the issues were. I know that we follow some patients with mucolipidosis who have continued to have thick aortic valves and leaky aortic valves. That kind of seems to be the standard picture. So enzyme replacement therapy is available for MPS 1, 2, 4, and 6. Nothing for mucolipidosis yet. Same thing after ERT, the cardiac squeeze is stable, coronary artery disease appears halted. The valves may continue to be thick, they may leak more, and in attenuated patients with MPS who get put on enzyme replacement, even if you're not put on enzyme replacement, it looks like the attenuated patients over time their valves can become stenotic, and that's different than the Hurler patients in whom stenosis is very uncommon. So in fact, this echo that I showed you from before with the mitral regurgitation, this is exactly the same patient only 10 years later. So this is somebody with MPS attenuated who developed mitral stenosis over a period of 10 years. So that's one thing that you need to keep in the back of your mind when you're seeing your cardiologist. So what do you do when you see your cardiologist? What we do here is get a baseline evaluation for everybody and then usually see them annually or every other year. and we see patients before they have major operations. That means a major operation is if you're going to have anesthesia for more than 1 or 2 hours, if you're going to be hospitalized for more than a day, or if you're going to have substantial blood loss. So you can think that we're talking about things like orthopedic procedures, big-time orthopedic procedures. Placement of a central line or something like that is not considered a major operation. So what do? We do a clinical assessment, ask how you're doing, any shortness of breath, chest pain, syncope, fainting. We get an EKG to see that you have normal conduction. Sometimes gags and storage material can get into the conduction system, and we can determine that on a EKG. If we've got any concerns, we'll do a 24-hour EKG, what we call a Holter. We'll do an echo. We'll measure 2 blood tests called a BNP and a troponin. A BNP tells us how much stress your heart is under, and it's used for any patient who's at risk for diastolic dysfunction or heart failure. And a troponin is a chemical that a test that shows if there's been any damage to the heart muscle cells. So we generally do these every year, and at some point we do a fasting lipid panel to make sure your cholesterol and triglyceride is okay. And then we send you to pulmonary for a pulmonary assessment as well. So before major operative procedures, we do all of those things, and we also ask you to go see the anesthesiologist so they make sure that they know how to handle your airway. That's probably one of the most important things that you need to have settled before you undergo anesthesia, that the anesthesiologist is comfortable with your airway. So when you need a cardiac evaluation, a center with experience is a good idea, not only for the cardiac support and the pulmonary support, but really for the anesthesia support. I can't emphasize that strongly enough, that that's probably the most important thing that you need to make sure of. So how do you find a center of excellence? Well, if you're in Europe, you go to this website here. It's called orpha.net, and this is the home page. And if you wanted to find an expert center, you'd click on this link, and it would take you to a spot that said put in your country, put in your rare disease, and up would pop all the doctors and hospitals in that country that took care of MPS. It's kind of cool. That's because the Europeans have had a concerted effort to centralize administrative stuff like this for rare diseases for almost 20 years now. If you do look in the United States, you can look at a rare diseases website from the NIH, and you can look at clinicaltrials.gov to find out information about the diseases and any current and previous clinical trials. But in the United States, there is no centralized place for you to learn about centers of excellence for MPS or any other rare diseases. And so you're left to look for mom blogs and parent blogs to help determine what's a good place to go to. That's something that would really be nice to have fixed so that there wouldn't be this odyssey of families trying to make a diagnosis and trying to find the best treatment. So MPS and MLS are very similar. Understanding your cardiac involvement is important, and not everybody is going to have a lot of leaking or a lot of stenosis. Some people have very little leaking or stenosis, and you need to have regular follow-up because it's a progressive disease. You have to find a medical home you're comfortable with, and then we have to do a lot more to get information out into the literature. So if anybody knows Sarah Cathy, she needs to put the echoes out for all the ML patients that she takes care of so that we know what the extent of the cardiac disease is in ML. Thank you.